So, dear students, we'll discuss a gastroscopy or endoscopic view finding and just see what it is. It's commonly seen in cirrhotic patient, chronic liver disease, alcoholic patient, but very important because it may cause sudden bleeding and life-threatening bleeding when you may not be able to control. That is just find out what is this endoscopic view. See that? See that? You can see that here. Esophagus lower third is there, and tortuous vessels. Varices. These are varices. These are varices. Usually in three positions. There again, commonly it is seen in three positions. Three positions are common. Varices in three positions like this. That is common. So 1, 2, 3 like that. So you can see the tortuous vessel commonly in the lower third. Sometimes may go to upper, then grade 4 like that. Below the carinal level, of course. Not uncommon to have anything above the carinal level. So that is what is this? Oesophageal varices. So one of the presentation of portal hypertension is esophageal varices. Other thing is ascites, splenomegaly, and of course there are three components, basic components: portal hypertension, esophageal varices, ascites, splenomegaly, and other features are there. Features of encephalopathy and nutritional deficiency, then recurrent infection, spontaneous bacterial peritonitis, then encephalopathy in its features, hepatorenal syndrome, then jaundice, hepatic jaundice they will develop because of non-functioning liver. So many problems will be there. Then umbilical hernia develop, and pleural effusion eventually they may develop. Then respiratory distress can occur, and eventually they go for a liver failure and becomes end-stage liver disease, wherein only liver transplantation is the answer, but still has got a very high mortality. So alcohol is a very common cause. There are so many other causes. In India, non-alcoholic liver cirrhosis is the common cause. 40% of cirrhosis is non-alcoholic actually. Unlike in Western countries, alcohol is the commonest cause. In India, nutrition, non-alcoholic causes are more common. Not more common, still it is identified common cause, 40% cases. So there is a point to which you have to remember. Esophageal varices is the more dangerous. Suddenly it may bleed to severe torrential bleeding can occur. Present as hematemesis and melena. Acute presentation as a tachycardia, hypotension, shock, present as a shock, sweating, tachycardia, hypotension, drowsiness, irritability, all those things. So usually occurs in the lower third of esophagus. 4 grades are there: 4, 1, 2, 3, 4. 20% of will have gastric varices also. So see that this is the esophagus, this is the stomach, like this, like this. This is the stomach. See that this is the esophageal varices will be here. Gastric varices are commonly here seen. 20% of varices, gastroesophageal varices together. But common is this one. Esophageal. This is the gastric. Sometimes combined. Isolated gastric varices, isolated varices, combined esophageal and gastric. Like that also different classifications are there. You can always go through my SRB's manual of surgery, liver chapter. It is clearly given. So this is exactly diagrammatically it represents the present with the hematemesis. So ectopic varices are rarely can occur in the duodenum, jejunum, other areas of the GI also. Most important thing is endoscopy is a confirmative, and if it is there, if a patient has a bleeding earlier, and grading like this, grade 2 or beyond, grade 1 you may leave it like that to treat the portal hypertension. Other grading you may have to do endoscopic banding or sclerotherapy. For gastric varices, gluing, banding is not possible. You won't be able to bend it. You won't be able to apply the band, whereas we have to put a glue into cyanocrylate glue into the gastric varices. Acute bleeding, other methods also there. Banding is the best method, and severe bleeding you may have to do put a temporarily. You have to place a sanguistaken black Moore tube where it's got a gastric balloon and esophageal balloon. Gastric balloon should be inflated with the 400 ml of air. Esophageal balloon is inflated with a 30 to 40 meter of mercury. First gastric balloon should be inflated, then esophageal balloon. And this balloon should be deflated every 12 hours. It's an MCQ question, every 12 hours. And to prevent pressure necrosis of the esophageal and gastric mucosa, that's important. It temporarily blocks stop the bleeding. It's only temporary measure. But eventually you have to do further specific therapeutic methods like banding, clearotherapy, or treatment of the portal hypertension. That's important. And still bleeding does not control, then you have to go for surgeries like Burima-Cryle esophageal resection, Burima-Cryle procedure wherein underrun the varices after opening the gastroesophageal junction, underrun all varices and then close. Again high mortality. Then of course Sugiura Futagawa operation where do splenectomy, part of the ligation of this one, then other procedures, again surgical procedure, HASA procedure, different procedures are there. Always you can go through my SRB's manual of surgery. But evaluation is very, very important. Transfusion of the blood transfusion is very, very important. 1:1:1. Pure packed red cells, plasma, platelet. One packed red cell, one plasma, one platelet. Like that you transfuse. Many times you may require a massive transfusion also. 5-10 bottles of packed cell, 5-10 bottles of platelet, 5-10 bottles of fresh frozen plasma, FFE. So blood transfusion is very, very important. Initial resuscitation is important. You may have to have a central line in this patient to manage catheterization. So of course, and then treating the bleeding. Stop the bleeding is again very, very important. Almost very essential. Everything should go parallelly. Correction, resuscitation, correction, then stop the bleeding. Everything should go parallel. Often vitamin K also you have to inject. So presentations are hematemesis melina, upper red blood plate, splenomegaly ascites may be present because of the portal hypertension. So injection octreotide and somatostatin is very useful, but they got a short half-life. Endoscopy I said, surgery I said, balloon tamponade also I said, single taken Blackmore tube, often asked MCQs, emergency surgeries I have told. And eventual surgeries are shunt surgeries. You got a selective shunt, non-selective shunt, and tips. It's a transjugular intrahepatic portosystemic stenting or shunting to endoscopic and to transjugular interventional radiology. They'll put across the jugular vein, across the IVC it comes, and then through the liver it put the stenting between the hepatic and portal system there inside the liver, and it acts as a bridge for future liver transplantation, and that's only temporarily too. But again it is a non-selective procedure. So it has got a chances of patient going for encephalopathy is very high. So we have to monitor, and if patient goes for encephalopathy, you have to treat them also. But it's a very good procedure because it's interventional one, not open, and it acts as a bridge for eventual liver transplantation. I've already told, final treatment in such a patient, cirrhotic with the chronic liver disease, with all this problem is liver transplantation. So control of encephalopathy, I already told, purgate, use protein-free diet, lactose, lactosol, neomycin, parenteral nutrition, vitamin K, plasma, blood. See, final treatment is liver transplantation. This is the only bridge. Tips. So further readings, SRB's manual of surgery, it gives every detail about the portal hypertension, including varices management, everything, liver chapter. Please go through that. Students, again I request, subscribe my YouTube channel, press the bell, and share video to others with your friends and colleagues, because every day brief lecture 5 to 10 minutes containing clinical case, then images, then operative procedure, post-operative complications, x-rays, instruments, clinical scenarios. So everything is there. Daily you can have the learning process about surgery and upgrade your surgical knowledge. Please again subscribe my YouTube channel and daily watch. Right, and MCQs are 2 MCQs are there. Go through it and put the right answer. I'll always appreciate and acknowledge your answer. There's a quotation also for your enlightenment. Please go through that also. Enjoy the video as a whole. So answer this MCQ. I appreciate your answer. So most common metabolic disturbance in cirrhosis is A, B, C, D. Put the right answer. I will appreciate that. And second MCQ is variceal banding is invented by A, B, C, D. Again put the right answer. Often asked these two as a common MCQ question, different exams. Again put the right answer. I will appreciate you. And quotation of the day is, pressure makes you more efficient. So without any pressure, you will be very lethargic. Some stress is required to learn, to go forward, go promote yourself. So without pressure, you won't learn at all. You will like a just sober you will be. So you need to have some pressure, not over pressure. Some pressure, some stress make you to learn everything and go ahead with your life and future. That is exactly meaning, which is very, very important for surgeons as such. So again, please go through, subscribe my YouTube channel, students, and share and press the bell. So students, I hope you have understood this lecture very well. Thank you so much.